two, one. Please start, sir. We are live.
Very good evening, dear friends, ladies and gentlemen. We always do the important topic scientific program. Most of the time, we have selected the topics which is basically burning in the sense of a clinical practice. And in this lung cancer conclave 2024, I want that we should discuss the important aspect of targeting therapies. And for that, we have three eminent speakers today. The first topic is a frontier in the first line treatment of ALK non-small cell lung cancer patient. If you see, majority of patients are EGFR positive, but I have seen few patients are ALK positive. What you will do in a present era is very, very important for us for discussion. Second topic is again a very important topic. We are talking about a CPS score, PDL1, immunotherapy roles in lung cancer, and for that we have new advancement of atezolizumab in first line treatment of lung cancer, again by our one of the eminent speaker, followed by the targeted therapies like decoding treatment option of EGFR mutation in non-small cell lung cancer by another experts, followed by a panel discussion on lung cancer. And for first talk, I would like to call our eminent speaker, Dr. Bharat Dua. He is a senior consultant at Narayana Super Specialty Hospital, Gurgaon. As an expert, he will talk on a frontier in the first line treatment of ALK positive non-small cell lung cancer. What is the present era? I would like to call Dr. Bharat Dua to give an insight regarding ALK positive lung cancer patient of
Good
Dr.
evening,
Bharat
sir. Am
Dua.
I audible?
Yes, Bharat.
All right. I'll just start my screen share.
Yes, Bharat.
So, is my screen visible, sir?
Yes, Bharat. Your
All
screen is
right.
visible.
All right. All right. In that case, good evening, everyone. My name is Dr. Bharat. I am a senior consultant in the Department of Radiation Oncology at Narayana Super Specialty Hospital, Gurgaon. And I've been asked to speak today on molecular biomarker testing in lung cancer. And without much further ado, I'll start my presentation. So this is the content of my talk. A brief overview of the position of lung cancer in India, biomarker testing in NSCLC, the evolution, past, current, and future directions, and key takeaways.
Sir, kindly make it full screen, please.
All right. It's okay. Is it not coming as full screen?
No, Bharat.
No, sir.
Okay, so just wait. Is it coming as full screen now?
No.
No, in that case, I'd ask Abhimanyu. Abhimanyu, just please load the presentation from your end.
Sure, sir, sure.
There seems to be some problem here, so I'll speak from your loaded presentation. I'll just stop my screen share and you can load the presentation. Right. So this next slide, please. Yes, we've been through this. Next slide, please. Yes, so a brief overview of the burden of lung cancer in India, as you can see in this slide, and this will be alluded to by the next speakers as well. The CA lung constitutes about 5 to 8% of all cancers in India, depending on how you sort of analyze the data. And it is the fourth most common cancer in India, as per this particular slide. Next slide, please. Yes, it's also the second most common cause in males. And next slide, please. Yes, this is just the incidence and mortality data of all cancers in India at present. And as you can see in this particular table, lung cancer is the fourth ranked cancer in terms of new cases and prevalence. Next slide, please. Can we have the next slide, please, Manu? Yes, this is a very important slide. What this slide actually shows us is that 50% of patients with advanced non-squamous lung cancer have a targetable driver mutation. And initially we had only 2 or 3. Now we have EGFR, ALK, ROS, KRAS, MET, HER2, BRAF, NTRK, PIK3, and MEK. And we also have targetable agents for each particular mutation, which have been approved by the FDA, and they are visible in this slide. Next slide, please. Yes, so the importance of biomarker testing in NSCLC is alluded to by this slide. As you can see, there is a marked difference in the survival curves, and this difference is sort of maintained over long term, which shows that this is the difference between a person who's receiving a targeted agent versus a person who's not. So as you can see in this particular slide, there's a median OS benefit of 7 months, although with newer targeted agents, it is much more. Next slide, please. So this particular slides highlights the differences in various guidelines, and in particular, in terms of KRAS mutation, there is a slight difference between the ASCO, the NCCN, and the CAP ISCLC. But if you look at the NCCN 2024 and ESMO 23, they definitely recommend testing for KRAS, particularly at codon 1213. And particularly because we have two targetable agents now, sotorasib and adagrasib, which have been approved by the FDA in KRAS mutant tumors. Next slide, please. Yes, this is a very important slide. This highlights the methods of tissue testing in NSCLC. And what I would particularly like to stress on this slide is that if you have insertions, point mutations, deletions, then the testing method is usually DNA sequencing, NGS or PCR, particularly for the indels. If you have fusion abnormalities where you're expecting an abnormal mRNA or a protein, then your RNA sequencing is slightly better than your DNA sequencing in terms of detecting the fusions. DNA sequencing or even targeted DNA PCR might miss some fusion abnormalities. And if you have an abnormal surface receptor or a protein, then your IHC and FISH comes into the picture. This is particularly relevant for PDL1 and HER2/neu. Next slide, please. Next slide, please. Yes, so well, this is a rather busy slide. So what this demonstrates is that there are various methods of collecting the sample for molecular testing. And it's not just a biopsy, but even a cytology that can be used for the testing, although a biopsy is always preferred. The method of processing continues to be FFPE, and you can run parallel diagnostics as is shown in this slide with an IHC and a FISH. For DNA assessment, the predominant methods are PCR, WAS, which is whole exome sequencing, or WGS, which is a whole genome sequencing. For your RNA testing, the methods are reverse transcriptase, quantitative PCR, and RNA sequencing. And proteomics, which is analyzing the proteome of a particular tumor, has really taken off in recent times, with fluorescent activated cell sorting of FACS being the most advanced technique to date for detecting proteome. Next slide, please. Yes, so the usual pathway is you establish a diagnosis, determine the histological subtype, and then go for your biomarker testing. It all starts with whether the tumor is squamous or non-squamous. And as per the current recommendation, for de novo metastatic lesions, both the primary and the metastatic sites are equally suitable. Bone biopsy is usually not recommended. Liquid biopsies are another option, but this is only recommended if you cannot get a biopsy from the primary tumor or the metastatic site, particularly in the de novo setting. The molecules that are recommended for testing are EGFR, ALK-ROS, BRAF, NTRK, RET, MET. And if you look at the ESMO and NCCN, HER2/neu and PDL1 has also been added to this. The TATs for various testing vary. They vary from about 2 to 3 days for an IHC-based testing to about 10 to 14 days for NGS. The upper limit is about 14 days. What is very important and is mentioned in the slide is when you have to do testing for all of these in a squamous NSCLC, which is in young individuals, which has been variably defined as less than 40, less than 35, never light smokers, or if the biopsy specimen demonstrates a mixed histology. Next slide, please. Yes, ctDNA testing, which is circulating tumor cell DNA testing, has the potential to be applied across all stages of NSCLC. So this slide actually highlights where all it can be applied. It can be applied at the level of diagnosis. It can be used to monitor prognosis. But again, one very important thing about this is that this sort of testing is only recommended in the de novo setting if you cannot get access from your primary or metastatic site. And that's why its role at present is considered complementary if you look at the ESMO 23 and NCCN 24 guidelines. Next slide, please. Yes, so an upcoming role of ctDNA is used to when it can be used to detect MRD, particularly after in the adjuvant setting post surgery. And as is highlighted by this particular study, the TRACER-X study, the ctDNA profiling was able to confirm MRD negativity with an accuracy of about 95% and detect MRD in patients who relapsed, again with an accuracy of more than 90%. And but again, the role at present, there's a slight debate amongst the guidelines in this, and the role at present is investigational. Next slide, please. So some of the advantages of a liquid biopsy are highlighted in this slide, and some of the disadvantages as well. A liquid biopsy is when we are taking the patient's blood and trying to analyze the tumor genome, the proteome, using either ctDNA or cfDNA or exosomes or TEPs. The procedure is relatively simple. You just have to draw a blood sample. It's minimally invasive, and there's a marked reduction in tumor heterogeneity, which is an issue with biopsies. However, because your cells, the cells that you get via this are much less than the amount that you get in a biopsy, we need very sensitive methods to detect ctDNA. And the standards have not been established, and the level of evidence at present is, depending on the guideline that you look at, between 2B to 3. Next slide, please. So there are two ways of doing gene testing. You can either do it sequentially, whether it is known as a single gene reflex testing, or you can do multiple genes simultaneously, as is done by NGS. If you look at the NCCN and ESMO guidelines, they recommend doing multiple testing simultaneously by NGS. Next slide, please. Coming to the advantages of NGS, next slide, please. Yes, so NGS has a number of advantages over single gene testing. As you can see, so what it does is it tests simultaneously for numerous markers. So what that does is you need a less amount of sample. You're testing for multiple markers simultaneously. You're getting your reports faster. However, the complexity of workflow and the standard protocols are still under development. Cost is obviously an issue. The main advantage is a shorter turnaround time if you go for a reflex testing versus an NGS. Next slide, please. Yes, so again, one thing that I'd like to highlight is single nucleotide variations and copy number variations is not something that's detected very well with the single gene, the Sanger sequencing, PCR methods. This is one of the advantages of NGS, that copy number variations are better detected, as is highlighted in this slide, by NGS versus your historical methods like Sanger sequencing, allele-specific PCR, and even mass spectrometry for that matter. Next slide, please. Yes, this is a very comprehensive slide. What this demonstrates is the various testing protocols that are used according to the gene that you're looking for. As is highlighted in this table, EGFR continues to be the most commonly detected gene with a detection a percentage of 30 to 40% amongst all patients who have a targetable actionable gene mutation. The method for detecting, because EGFR mutations are usually point mutations and deletions, the method of choice continues to be a PCR or an NGS. And the same goes for a KRAS, with the G12C mutation being the most common. If you come to MET mutations, again, because MET often has skipping mutations as well as amplifications, depending on what you're expecting, or if you're looking for a broad-based test, amplification or PCR both play a role. If you're looking for an amplification, then you need FISH or amplification FISH. And if you're looking for mutations, you need PCR. ALK, which is a receptor tyrosine kinase, the predominant mutation that is seen is ALK fusion, with the EML4 ALK being the most common. So the predominant method of testing will be either a FISH, IHC, or an NGS. Coming to BRAF, BRAF again, the most common mutation is a V600E, and so PCR will be the dominant test. And again, there are other mutations mentioned in this as well. Again, ROS, if you look at the table, ROS again undergoes predominantly fusions. So wherever you have a fusion, you will either have an RNA-based PCR or an IHC FISH-based testing or an NGS. And the same is highlighted for the other markers as well. HER2/neu testing, again, because HER2/neu shows amplifications, your FISH, your NGS, and your PCR, all three will play a role in HER2/neu testing. Next slide, please. Yes, a bit of a mention of EGFR mutation in lung adenocarcinoma. Next slide, please. Yes, so as I mentioned, FFPE sections are the best. Cytology samples are also suitable if you can make a cell block. The important thing is that discordances between EGFR mutation status between primary tumors and corresponding metastatic sites are rare, and which is the reason for the NCCN and the ESMO recommendation that either site can be suitable for EGFR testing. Next slide, please. Yes, the role of EGFR testing in early lung cancer has come up in a big way now. Can we have the next slide, please? Yes, this is the NCCN 21. But again, even the NCCN, if you look at the NCCN 23 and 24, EGFR testing is a big part of early stage lung cancer analysis as well, with adjuvant TKIs coming in the adjuvant treatment of lung in a big way. Next slide, please. Next slide, please. And again, one very important advantage of NGS over PCR, and I cannot highlight this enough, is that NGS can sometimes detect mutations that PCR would otherwise miss. And this particular slide highlights that. This was just one particular study, but on an average, it's mentioned, if you look at various studies, that about 10 to 20% of mutations that can be detected by NGS are missed by the PCR. Next slide, please. Coming to the importance of ALK rearrangements in SCLC. Next slide, please. Yes, so for ALK, one very important mention is that IHC is almost as sensitive and specific as FISH. The false positivity rate of 0.1% with FISH is a little more with IHC, but IHC is being widely adopted because its sensitivity and specificity for ALK is more than 95% in both cases. Next slide, please. Coming to the role of ROS rearrangement in SCLC. Next slide, please. Yes, so this is the recommended algorithm for ROS testing. It's basically using your IHC to screen for the mutation and using the FISH as a confirmatory test. This is routine practice, and this has been adopted by most guidelines. There is no sort of controversy here. You test initially by an IHC, and if the patient, if it turns out to be ROS positive, you confirm it with a FISH. And if it's ROS negative, you can be reasonably certain that you won't be detecting a ROS mutation. Next slide, please. Yes, so highlighting the role of KRAS, again, one very important thing that we all need to know is that KRAS mutations are mutually exclusive with EGFR and ALK. And again, as I mentioned in the previous slide, whereas EGFR mutation are seen in 30 to 40%, KRAS mutations are seen almost in 20 to 30%. And as I mentioned before, the most common of these are in codon 12 and 13. We do have targeted agents, and these are both FDA approved and are mentioned by the NCCN. The two agents are sotorasib and adagrasib. Again, so since it is a single gene KRAS mutation that we are looking for, we'll use a NGS panel to detect it. And one of the important reasons for detecting KRAS is that these patients are usually resistant to EGFR inhibitors. Next slide, please. Yes, so this is very important. BRAF mutations have come up in NSCLC. The most common mutation is V600B, and while this is the most common, it is not the only mutation that is seen. The other mutations like V600K is also seen in about 10 to 15%. Overall, BRAF mutations occur in 1 to 5% of NSCLC, most commonly adenocarcinoma. These are seen very rarely in squamous cell cancers. We have agents to target the BRAF. These are similar to the agents that are used in skin cancers and melanomas. The drug is dabrafenib. Now, it is usually combined with a MEK inhibitor, which is trametinib, to reduce the incidence of second skin malignancies. Next slide, please. Yes. So another receptor tyrosine kinase which has come up is c-MET. Its normal role is in embryogenesis and wound healing, and the mutations that are usually seen are in-frame mutations. Which means that a truncated protein is usually generated, which retains partial function. These are seen in about 3 to 4% of lung cancers and are particularly common in the sarcomatoid variants. And again, since they are mutations, they can be detected with DNA NGS. However, for these particular mutations, there is some data that suggests that there's an increased sensitivity with RNA NGS. Next slide, please. So what is, again, they want to highlight how you test for a MET exon 14 mutation. The method of choice is obviously an NGS. The DNA NGS detects most of the mutations, but as is mentioned in the paper below, the current modalities that is the most sensitive for detection is the RNA NGS. Next slide, please. Another receptor tyrosine kinase that is often seen mutated in lung cancers is the RET. So this is also seen in thyroid cancers, as is mentioned in this particular slide. It is seen only in 1 to 2% of non-squamous NSCLCs, very rarely in squamous. And again, for this particular receptor mutations, RNA NGS has a slightly higher sensitivity than DNA NGS, which they want to highlight in this particular slide. Next slide, please. And again, what they want to highlight is, again, the same thing that is mentioned in the previous slide. Most of the mutations can be detected by DNA NGS, but RNA NGS has slightly increased sensitivity as compared to DNA NGS to the tune of about 10%. Next slide, please. Yes, so testing for NTRK fusions, the ESMO working group recommendation chart is given in this particular slide. Again, what they want to highlight is that for all of these receptor tyrosine kinases, RNA NGS is most sensitive. Although IHC is available and has a faster TAT, reflexing to NGS versus IHC is reasonable due to low prevalence. So they recommend reflex testing in this case. If there is a sequencing platform available, they always recommend NGS. If it is not, they use IHC as screening tool, something similar to ROS. If you detect any TRK expression, you usually use NGS to confirm it. Next slide, please. Again, we've alluded to this repeatedly that if you compare IHC versus NGS for any sort of fusion detection, IHC will give you rapid results, but NGS always will be more sensitive. The specificity may be the same, but NGS will be more sensitive for certain mutations. Next slide, please. Coming to HER2 mutations, and this is a very important recent development. This has developed over the last 2 or 3 years with the advent of trastuzumab deruxtecan. They are present in 3 to 5% of lung cancers, and the most common mutation is an exon 20 in-frame mutation. It's mutually exclusive and obviously portends a worse overall survival if you don't use a targeted agent. The approach to HER2 detection is quite similar to breast cancer, with IHC being used quite often. And next slide, please. Okay, so this slide is here, I thought. Yes, so this is a brief summary of all the recommended testing. This came about in 2022, And I believe HER2 testing has been added to this in the ESMO 23 and the NCCN 24 guidelines, but I will again just discuss this slide for completion's sake. So firstly, they recommend that you do a testing for EGFR, and particularly for the classical mutations, deletion 19 or L858R on chromosome 21. And the drug of choice is osimertinib. They also recommend that you do an ALK testing, and the drugs that are recommended for ALK mutants are alectinib, brigatinib, or lorlatinib. For ROS, the drugs available are crizotinib or entrectinib. And for BRAF, I just mentioned dabrafenib, combined with a MEK inhibitor, trematinib, is usually the initial drug of choice. And for NTRK, now we have two drugs, entrectinib or larotrectinib. For RET mutations, we have selpercatinib or pralsetinib. For MET exon 14 skip mutations, we have capmatinib or tepmotinib. And for KRAS G12C, we have sotatercept and now adagrasib. Next slide, please. Coming to a very important topic, PD-L1 overexpression in NSCLC. Next slide, please. Yes, so what is important is we all need to know this slide. It's important that the testing is done on the recommended platform, and we should be in particularly aware that for pembrolizumab, this is companion testing. For all others, it is complementary, which means if you want to give pembrolizumab, you need to get these tests done. Various scoring systems are there. And for the particular agent to be used, you should allude to the initial trial. Next slide, please. Yes, as I mentioned, different antibody clones are used, and it's very important that the testing be done on the clone as it was used in the trial. Next slide, please. Yeah, so again, which biomarker to be used? This is still an area of controversy, although we do have trials and we do have recommendations regarding how to test. There is still work going on. The role of PD-L1, do some patients respond who are PD-L1 negative? Is there a synergistic effect with chemotherapy? What exact cutoff to be used for various agents? What is the role of tumor mutational burden? The checkmate studies have really sort of put tumor mutational burden on the back burner. And what is the role of MSI testing? This is not really being explored in lung cancer. And what is being explored is other immune inhibitory checkpoints besides PD-L1, particularly LAG3, TIM, and VISTA. These are still being studied, and no particular recommendations regarding their testing exist in any guidelines as so far. Next slide, please. Yes, so I'd just like to conclude. Biomarker testing in lung cancer has evolved from single gene to multiplex testing, as is recommended by the latest NCCN and ESMO guideline. And they always encourage a multidisciplinary approach to testing. Again, adequate tumor content. The current recommendation is 10%. The ideal TAT is 2 weeks. It's 10 to 14 days for NGS. It's 2 to 3 days for IHC. It is about 3 to 4 days for PCR. You should refer to the guidelines for this. And the general recommendation is that you should use high throughput multi-gene testing platforms such as NGS upfront to screen for several genes simultaneously to reduce the TAT. Thank you.
Thank you, Bharat, for such an excellent talk on a biomarker. Means it's a wonderful talk because a biomarker is the basically a recent treatment in adenocarcinoma lung or even in squamous cell carcinoma. We always go for NGS to see which marker is positive, and according to that we plan the treatment. And I just want to call the another speaker on an overview of lung cancer, because once we know the magnitude of this disease, then and then we can say that this is the ultimate incidence and mortality and survival of lung cancer. And for that, I would like to call Dr. Jyotika Jain. She will talk on review of lung cancer, overview of lung cancer in clinical practice. Dr. Jyotika Jain, she is the director of radiation oncology at Narayana Hospital, Gurgaon. Dr. Jyotika Jain, please.
Sir, thank you very much for giving me this opportunity. I would like to request organizers for sharing the slides, please. Excuse me. Am I audible?
Yes, ma'am, audible.
Yes. So, thank you very much for giving me this opportunity. So, we are going to discuss the overview of lung cancer just now. Dr. Bharat has already made this work much more easier for me. So, if we see the burden of lung cancer as per Globocan, next slide, please. Already discussed, like it is to the tune of 5.5%. If we see in males, this is the second most common cancer in males. Can you just move the slide, please? So as we have already seen, if we see any new number of cases of lung cancer, they are to the tune of 72,000, 5.5%, and death rates, they are quite high, 7.8%. So almost 66,000 people, they die each year from lung cancer. Next slide, please. If we see, if for any treatment, we just need to know the good staging, adequate optimal staging of cancer. So if we see AJCC 7th and 8th edition, there are few changes we must notice, like size of the tumor, which used to be 5 to 7 centimeter, up to 7 centimeter, that used to be in stage 2, but now this has changed to stage 3A. So a lot of changes they are there in the two staging. So we must know about that. Please, next slide, please. So how to go ahead with exact staging? So there are various investigative tools for that. So if we require basically bronchoscopy, CT chest, PET CT, EBUS, EUS, mediastinoscopy, or MRI brain. So various modalities, they help us in defining the exact stage of the disease. Next slide, please. Now, if we compare CT chest and PET CT for staging of NSCLC, if there are lymph nodes on the CT which are more than 10 millimeter in the short axis, they are suggestive of malignancy. CT alone as such has low sensitivity and specificity. Sensitivity is to the tune of 55% and specificity is the tune of 81%. But CT helps us in taking the tissue sample. Normally all the biopsies, they are done most of the times under CT guidance. If we add PET CT along with the CT, then its sensitivity increases to 80 to 90% and specificity increases from 85 to 95%. Next slide, please. Now, there are a few more factors which we need to know, like whenever we are doing any imaging, we might have occult N2 disease, which will modify whole of the treatment plan. So there are few factors which must be there in our mind. If any central tumor is there, or if the size of the tumor is more than 3 centimeters, or if we see the SCV on the PET that is more than 4. So all these factors, they are predictors of more probability of N2 occult disease. So all these factors, they have to be kept in our mind while staging a patient. Next slide, please. So normally for medicinal staging, you require EUS or EBUS biopsy. But if any doubts they are there, and if a strong suspicion is there and biopsy is not feasible by EUS or EBUS, then we might require mediastinoscopy. Next slide, please. So along with that, like if N2 disease we are suspecting, we might require surgical mediastinoscopy in many cases. Next slide. So when to do invasive mediastinoscopy? When any centrally located tumor is there, in those cases, we should go ahead with that. If tumor size is more than 3 centimeter, in these cases, extensive infiltration of mediastinum with any evidence of thoracic disease or node positive N1 disease, in these cases, we should go ahead with mediastinoscopy. Bulky N2 on CT, there is no need for invasive confirmation. But if discrete N2 is there, yes, regardless of PET results, we should go ahead with that. If normal mediastinum on CT and positive on PET, we go ahead. But if PET is negative, we can omit that. Next slide, please. So whole of this an algorithm is there. So depending, as we have already discussed, if positive or negative, how we proceed further for staging of the mediastinum. Next slide, please. So we must know, like, there are various stations which are accessible by one or the other modality, like EBUS, TBNA, EUS, VATS, MAMLA. So basically, wherever, what is the location of the tumor, we have to combine the various modalities for exact lymph nodes identification and staging of the tumor. Next slide, please. So we have to combine various invasive as well as non-invasive modalities so that we can get a good sensitivity and specificity for detecting the disease extent. Next slide, please. Now, if we see there is really an evolution of therapy in the lung cancer. Earlier, it used to be small cell, non-small cell, and later on, different types of non-small cell, then molecular testing, EGFR, AL, cross, and then EDL1, tumor mutation burden. So now whole of the paradigm that has shifted from simple small cell, non-small cell carcinoma to the more targeted, basically targeted oriented radiation treatment modality. Next slide, please. So it has been seen because of the various advancements, the lung cancer specific survival, which used to be to the tune of 26%, now that has increased to 35% in 2014, and it has been seen basically there is a reduction in the incidence along with treatment advances, particularly which is more advancement in a lot of targeted agents, which is leading to improved survival in lung cancer. Next slide, please. So if we see early and late stages of lung cancer, there are various targeted and immunotherapy which is available. A significant increase in both approval of both targeted as well as immunotherapy in lung cancer is there. We can see from each year onwards, like Dr. Bharat has already covered most of them, like we are having a large number of targeted agents depending upon the mutation. Next slide, please. So if we see now molecular profiling of all non-small cell lung cancer, that is basically a standard of care. It is increased the need of, there is an increase of molecular need of molecular testing of non-small cell lung cancer. At least these 7 major alterations, which are EGFR, AL, cross, BRAF, RET, MET, all these testings, they are basically must so that the further treatment can be planned accordingly. Next slide, please. So if we see the current guidelines on neoadjuvant and adjuvant chemotherapy, depending upon stage and finding during surgery. So if 1A disease is there, in this it is recommended observation and no neoadjuvant or adjuvant chemotherapy is there. But if it is 1B, 2A, in this you require adjuvant chemotherapy in high-risk patients. If it is 2B, node positive disease, adjuvant chemotherapy is recommended. And if it is 3A, 3B, node positive, in those cases, neoadjuvant chemo, adjuvant chemo, or sequential chemoradiotherapy in N2 disease is recommended. Next slide, please. So there are a few factors also on the basis of which adjuvant treatment is decided. As we know, R0, R1, R2 resection. If it is R0 resection in early stage observation, if chemotherapy is given in high-risk patients when it is 1B or 2A, if it is node positive disease, chemotherapy. If it is N1, N2 disease, RT only in N2 disease, but otherwise chemotherapy, or either it is sequential or concurrent. If incomplete resection is there, R1, R2 resection is there, in those cases, re-resection is preferred, or we can go ahead with chemotherapy. If it is 2B disease, in this re-resection plus chemotherapy, or CTRT if it is R1, R2, and in stage 3A, CTRT sequential or concurrent, or chemo RT concurrent in R2 disease. Next slide, please. So after initial treatment, more than half of the patients with resectable non-small cell cancer, they experience recurrence within 5 years. We see almost 50 to 60% of the patients, they either fail locally or distantly in spite of surgery, chemotherapy, radiotherapy. Next slide. So they're in ESMO guidelines, they have seen that in 1B disease or tumor which were more than 4 centimeters, there was a clear-cut advantage of adding adjuvant chemotherapy. So this was a standard of practice. Adjuvant chemotherapy was an option for 1B disease and high-risk features with the tumor size was more than 4 centimeter. Next slide, please. So LACE meta-analysis was there in which they pooled the analysis of 5 trials in which they use adjuvant cisplatin-based chemotherapy. They used cisplatin and vinorelbine, and it was seen that there was an absolute benefit of 3.9% and 5.4% at 3 to 5 years, respectively, with addition of chemotherapy. Next slide. How well we can use neoadjuvant as well as adjuvant chemotherapy. So it was studied in a meta-analysis, and it was seen that neoadjuvant chemo as well as adjuvant chemo, they were having similar hazard ratio and they were equally effective. Next slide, please. Now coming to targeted therapy is now moving in early stage lung cancer. As per ADORA trial, it was seen when patients there was improvement in disease-free survival with osimertinib in resected EGFR mutated non-small cell lung cancer. We can see the graph. There was almost improvement, disease-free survival improved from 44% to in the placebo group to 90%. So it is now possible to further improve survival in completely resected stage 1 to 3 non-small cell lung cancer. Next slide, please. Now coming to atezolizumab, that also showed improvement in disease-free as well as overall survival. And it has been seen that it has shown a survival in the adjuvant setting in patients who have PD-L1 positive more than 1%. So such therapies will help improve survival rates in non-small cell carcinoma. We can see from the graph, there is significant improvement in the median survival in the 2 groups. Next slide, please. Now coming to role of radiation, in earlier days, there used to be simple type of radiation where APPA type of fields or 3D CRT were used. Now we have advanced techniques like intensity modulated radiotherapy, where we can make the shape of the vein. We can have modify the intensity of the beam. So it has been seen that there is improved survival in the patients with stage 3 lung cancer with IMRT, and you can decrease the dose to the heart and lung, and for complications of pneumonitis and cardiac toxicity, all that can be decreased with the help of newer modalities. Next slide, please. Now, some of the important things pulmonologists should also know, like conventional and stereotactic radiotherapy. In conventional, we use normal fractionation 1.8 to 2 gray, but in stereotactic radiation, we use higher dose of radiation, so 8 to 20 gray per fraction, and radiation is delivered in 1 to 5 fractions. Quick treatment, but very high dose is given, and normally that is done when lesion is small, around 5 centimeter. If nodes, they are not there. In those cases, we prefer to use SBRT, early stage disease. Otherwise, we go ahead with conventional IMRT, 3D CRT. Next slide, please. So now we are having a lot of new modalities which are helping us to define the volume, target volume, which you can just minimize the target volume. You have a 4D CT planning, which helps us takes motion into account, and you can do image guidance, like patient is on the machine and you see how much tumor is moving, and accordingly you can give very small margins around the tumor. So normal structures, they can be saved very well. And you can go ahead with adaptive radiation. Suppose some large lesion is there, you are irradiating that, and after that some collapse was there that has opened up. So you can just replan the patient, and normal structures, they can be saved very well with the help of new techniques. Next slide, please. Now, there was a trial from RTOG 0617, which has evaluated the role of escalation of the dose, whether that is helpful or not. And in that, they added cetuximab along with chemotherapy. So it was seen there was no added benefit of escalating radiation dose, and there was no added benefit of a cetuximab addition. Next slide, please. Again, so we are just seeing chemotherapy with or without radiotherapy is the standard of care after completely resected patients. This we have already discussed, like adjuvant treatment. If 1A disease is the observation, if 1B, 2A, you require adjuvant chemotherapy, or if 2B node positive disease, chemo is added, and if 3A, 3B disease there is chemotherapy or sequential chemoradiotherapy in N2 disease. Next slide, please. Now coming to another, now there was a trial, Pacific trial, which was a randomized double-blind placebo-controlled phase 3 trial of consolidating durvalumab in the unresectable non-small cell lung cancer. So durvalumab demonstrated basically overall survival advantage at 5 years, which was 42.9%. If we see on comparison with the historical trials, which used to be 15 to 25% 5-year survival rate. So it is checkpoint inhibitor, which is helping us in improving the outcome in advanced stage lung cancer. Next slide, please. Now coming to the emerging treatment paradigm, like targeted therapies and immunotherapies, I think they are going to make the future of all treatment in lung cancer. Next slide, please. So targeted therapies, they are improving the outcome in lung cancer. So it has been seen that earlier it used to be disease with median survival used to be 5 to 7 months, and now with EGFR inhibitors, it is to the tune of 18.9 months, and with the help of ALK inhibitors, it is to the tune of 34.8 months. So our results, they are improving slowly from 5 to 7 months to 34.8 months. Next slide, please. So now other molecular genetic testing, as Dr. Bharat has already dealt with most of them, we are having specific targeted agents like crizotinib, cabozantin, and like if we have to be more specific, whatever mutation is there, and we have to target that. So newer targeted agents are being identified, which is helping us to increase the survival in these subset of patients with mutations. Next slide, please. Now, if we see the survival outcomes with the recent advances, the survival rates, they are improving quite a lot. If we see with chemotherapy, it used to be 4 to 8 months. And if we see with osimertinib, we can see it is almost 39 months. So we are really on the betterment side with newer drugs. Next slide, please. Now coming to immune checkpoint inhibitors, which are basically CTLA4 blockade or PDL1 or PD1 blockade. We are using basically body's own immune cells to fight the cancer. Next slide, please. So if we see whole of this slide is showing how we have shifted from 2015 to 2022 and later on. Like initially we were using MABs for earlier pembrolizumab, and now we are moving ahead. Each year we got approval over time, and now atezolizumab, nivolumab, ipilimumab. So we are moving ahead with a lot of newer drugs which are getting approval for lung cancer. Next slide, please. So if we see with survival benefit again with immune checkpoint inhibitors, we can see earlier it used to be quite small, 4 months, 8 months, 6 months. Now we are moving ahead 20 months, 30 months. So we are basically based on histology and PDL1 status, we can use immune checkpoint inhibitors and we are getting better outcomes. Next slide, please. So we can clearly see there is advantage of with the in stage 4 lung cancer. If we are using that, there is clear cut 16.3 to 31% overall. These two graphs, they are really wide apart and we are getting a lot of benefit with immune checkpoint inhibitors. Next slide, please. So almost 32% patients are alive at 5 years with the use of immune checkpoint inhibitors in metastatic non-small cell lung cancer. Next slide. So now checkpoint inhibitors, they are moving to the early stage 1, 2, 3 also, and multiple ongoing trials. They are studying studying immune checkpoint inhibitors in the adjuvant setting. Let us see the results, and further they'll be helping us in future. Next slide, please. Now, what is new, like antibody drug conjugates, which are basically approved therapy in the breast cancer. This is coming up in near future, which might help us further in non-small cell lung cancer. Next slide, please. So CAR T cell therapy, another new era in the cancer immunotherapy, where our own body's immune system is stimulated through the tumor, and those cells, they are re-injected inside the patient so that our own immune system fights the cancer. Perhaps in future that might give us answer to many more in lung cancer. Next slide, please. So key takeaway message, I'll say the management of management landscape is really changing very fast, and newer therapies, they are having huge potential in improving survival, especially when detected in early stages. Overall survival is improving across various subtypes with molecular alterations. The ease of oral pill or infusion in case of targeted therapy is an added advantage. And pulmonologists will play a huge role in the early diagnosis, hence it is crucial to involve them in the non-small cell lung tumor boards. Thank you very much. Thank you.
Thank you, Dr. Jyoti, for such an excellent talk regarding the checkpoint inhibitors, the role of IMRT, IGRT in lung cancer, what are the indication and what are the randomized trial says. And I personally feel that Dr. Bharat Dua talked about the biomarker and you talked about the overview of lung cancer. The question is, we have first generation, second generation, and third generation TKI. A number of times the question is, which one is better and why? And for that, decoding is very important. And for decoding of the molecular targets in EGFR mutation positive, I would like to call Dr. Sumit Goyal. Dr. Sumit Goyal is an Associate Director of Medical Oncology at RGCI. So what is the new things regarding the TKI? Should we go for a first generation or second generation or third generation? Dr. Sumit Goyal will decode the treatment option of EGFR mutation metastatic non-small cell lung cancer patients. Dr. Sumit Goyal, please.
Good evening, sir. Thank you very much for giving us this opportunity today. So, as dealt before by previous speakers, and as you have put forward, my topic today is decoding treatment option for EGFR mutated non-small cell lung cancer. So very briefly, I'll be talking about the role of EGFR agents in metastatic non-small cell lung cancer. So if you look at the data worldwide, at all the cancers together, so we know that lung cancer and the breast cancer, they are the two prominent cancers which we see. They are the most common in both male and females. And if we look at the mortality, however, the lung cancer is the one with the leading mortality. It surpasses lung cancer. Breast cancer, the incidence is 11.7%, most common cancer, but mortality is half. But if we look at the lung cancer, it is almost equal or more when we look at the lung cancer. So there is an unmet need to find more data, and lung cancer has served as a uh, like a blue-eyed boy of precision oncology. So it has given us lot of insight, and we are trying to replicate same thing in other cancers. So if we look at the same thing which I said earlier, uh, it is the leading second most common cause of cancer and leading cause of death. So if we talk about the parameters, so when we talk about choosing a drug, the things that comes to our mind, definitely there are disease related factors, there are patient related factors. But what comes to our mind, we definitely want OS advantage. We want advantage in terms of PFS. We want disease to get controlled very rapidly. So we definitely look at overall response rates. So again, lung cancer is a disease where there is a possibility of presence of brain mets at presentation or during the course of treatment. So we want to know what is the status of the brain mets. And again, whatever we are using, we look at safety and toxicity of the drugs that we are going to use, which are important to maintain the quality of life. And again, it is important to know uh, the subsequent therapies. Are there any subsequent therapies which are available to us in the future? Suppose the patient progresses. So that is also important for us. And so if we look at the drugs which were available to us in EGFR mutated lung cancer, we had gefitinib, erlotinib, afatinib, dacometinib, and osimertinib. So these drugs, first generation to third generation drugs, they have come a long way, both in improving the outcomes and survival. So gefitinib, we know in IPA study, the median PFS was 9.5 months. Whereas in third generation, it has almost doubled with osimertinib, which was shown in the FLORA study. And again, erlotinib, afatinib, dacometinib, with different toxicity and drug profiles, they were there. And if we look at the efficacy, if we look at the progression-free survival, so we have three different studies: Lux Lung 7, which compared afatinib with gefitinib. We had Archer, which compared dacometinib with gefitinib, and which we have Flora, which compared osimertinib with standard of care, which was the other TKIs, gefitinib or erlotinib. So if we look at the curves, first curve, in Lux Lung 7, the brain mets were included, and almost 16% of patients they had brain metastasis, but the responses were similar. And if we look at though the hazard ratio is favoring the afatinib arm, if we look at the median PFS, it was 10.9 versus 11 months, and the responses came quite late, close to 12 months. Archer, it was little better. Dacometinib versus gefitinib, but it was almost 6 months before the benefit was visible. Whereas in Flora study, we could see that the patients had immediate benefit. Like it is, you can clearly see the curve started to separate quite early. So again, we need to remember this is cross-trial comparison, and there is no head-to-head comparison. So the early separation, again, which was clearly visible here in all the studies. Again, the important point, response rates. In Lux Lung 7, the responses were higher in the second generation afatinib as compared to gefitinib, 70 versus 56%. And the duration disease control rate was there for 12.7 versus 11.11. And in Archer, if we look at the Archer study, the response rates were little better, 75% versus 72%, favoring the dacometinib arm. There were more complete responses, partial responses, stable diseases. And the median duration of responses, it had increased from 12.7 to 14.8 months as compared to 8.3 months in the gefitinib arm. Then coming to the Flora study. So again, the overall responses, they further improved to 80%. And the percentage of responses, they were there in the more number of people. We can clearly see, and the disease control rates were much higher. And osimertinib has shown the highest overall response rates and median duration of responses. So if we look at the overall survival, which was shown in the final analysis when the study was presented, So clearly, osimertinib, the median OS was 38.6 months as compared to 31.8 months in the comparator arm. So hazard ratio of 0.79 favoring osimertinib. And clearly, the more people were alive at 2 and 3 years. The median was much higher at 3 years. And the patients who were taking osimertinib, they were more likely to be alive at second and third years. And again, this was the study which showed the first time that PFS advantage has translated to a significant OS benefit. So if we look at the LuxLung 7 and Archer studies, so in the Archer 1050, though the values were numerically superior, uh, probably trying to say that tends towards improved OS benefit, but however, they had statistical hierarchical method which said during which it was said probably it is not there. So if we look at the oncology current the same thing here, though the numerically the dacometinib had shown benefit, but it was not statistically superior. So it did not meet the significant OS benefit was not there in dacometinib arm. So same thing again, if we look at the osimertinib, the patients at 3 years, about one third of patients were still receiving osimertinib at 3 years. So which was not heard of. It was uh, as compared to first generation, only 5% of patients were on treatment at the time of data cutoff. So if we talk about the superior systemic PFS benefit, so when we talk about the disease, whether it was with the CNS disease or without the CNS disease, again, the median PFS with the patients who had known or treated CNS metastasis, the median PFS was 15.2 months as compared to 9.6 months in the standard of care arm. So again, the hazard ratio of 0.47 favoring the osimertinib group. And if we look at without known or treated CNS metastasis, the PFS advantage was much higher, 19.1 versus 10.9, favoring the osimertinib arm. So clearly, osimertinib works intracranially. The CNS progression events occurred in 6% of patients as compared to 15% of patients receiving first generation of TKIs. So again, intracranial PFS, CNS, if we look at the full set analysis, so in the osimertinib arm, the median PFS was not reached, whereas it was 13.9 months in the standard of care arm, hazard ratio of 0.48, and the CNS PFS was statistically significant with osimertinib as compared to the comparator arm. So again, the same thing. If we look at the CNS benefit, so intracranial CNS responses was not assessed in the LuxLung studies, whether it was 3, 6, or 7. And systemic clinical benefit was observed with afatinib versus chemotherapy, but not versus gefitinib. And systemic and CNS clinical benefit were observed with osimertinib as compared to the comparator arm. And in the Archer 1050, the patients with brain mets were excluded. And in the other global clinical trial programs with first generation TKIs, the data on brain mets is not there. So here again, the osimertinib clearly showing it has intracranial activity with significant response rates, and median CNS PFS not achieved versus 13.9 months. So again, coming to the other equally important question, safety. If we look at the safety profile, the grade 3 or 4 adverse events with dacometinib were reported in 63% of the patients, the Archer 1050 patient study. And in the afatinib arm, it was reported in 31% of patients in LuxLung 7 study. But once we talk about the FLORA, in FLORA, the more than or equal to grade 3 adverse events were there in 18% of the patients. Again, the side effects it was either diarrhea or fatigue, which we know how to handle. And And we have our learning curve with these drugs. So again, the same thing, the skin rash, paronychia, diarrhea, stomatitis. If we look at the serially from afatinib, dacometinib to osimertinib, so the skin toxicity or paronychia or diarrhea or stomatitis, it was least with the osimertinib arm, less than 1%. The skin rash, we from earlier days, uh, we had a difficult time in managing the skin toxicity and paronychia, but now with osimertinib we have rarely seen these side effects. So again, the important point is dose reductions. So the second generation TKIs, apatinib and dacometinib, have been shown to frequently cause adverse events, which have led to dose reduction. In Lux Lung 7 trial, almost 41.9% of the patient had to reduce their dose as compared to 1.9% in the first generation, as compared to the first generation TKIs. In Archer 1050, almost 67 for two-thirds of the patients, they had to reduce the dose as compared to the comparator arm. But in the Flora study, it was almost equal as compared to the first gen drugs, 5%, 5% versus 4%. So very less dose reductions which were required with osimertinib. So if we talk about again quality of life, Archer 1050 versus Flora. In Flora, the global quality of life was improved from baseline in both osimertinib and EGFR TKI group with no clinically relevant differences. But in Archer, the quality was maintained with the dacometinib, but and was improved, but it was not considered meaningful improvement as compared to the gefitinib group. So again, the sequencing part. So which drug to give upfront? So shall we start with the most potent drug first, then we move on to give the next potent drug, or shall we start with the most potent drug upfront? So if we start with, so theoretically there is a rationality. We start with the first or second generation drug. On progression, we should go on to the receive the third generation drug so as to prolong PFS. But in real practice, it is not so. So we know with continuation of treatment, there are likely to be dropouts. There is likely to be progression. So if we, for example, if the 10 patients are started on first line treatment, the one third of the patients are likely to progress and they may not receive the second line treatment, meaning almost 70% patients will go on to receive the second line treatment. And again, if they go on to receive, then there are patients who are likely to have T790M test, and they may not be eligible for repeat tissue biopsy to know whether they have T790 mutation. Again, if those patients who are tested, they do test positive, only 3 out of 10 will be eligible to receive osimertinib in the second line. So otherwise, so again, the most important thing is it is not easy to predict who will develop T790M resistance. So again, access to second line therapies. So this is there in this chart in different studies from IPAS to ensure optimal URATAC. So in standard of care TKI arm, almost one third of patients will not have access to second line treatment. So we need to use our most potent drug upfront. So when we talk about the real world evidence, whether it is so, in studies, we know the very fit patients are selected and they are under close scrutiny. But in a real world, uh, the evidence of T790M after afatinib. So we know in Japanese study, out of 37 patients, only 43% acquired T790M. In Taiwanese study, 48% of 42 patients who were rebiopsied were after afatinib failure had acquired T790M. In another study from Taiwan, only 32% of the patients had acquired T790M patients, meaning if they had received afatinib, they were not eligible to receive osimertinib later on. So we don't know, but data says less than 50% of patients put on afatinib require T790M mutation. So to look at sequencing, starting with prior generation EGFR TKIs, then treating those that develop T790 with osimertinib. This is not an optimal clinical care scenario because first thing, we are not smart enough to figure out who will get the EGFR T790M mutation. And again, we know one third of patients, they will anyway not be eligible to receive the subsequent therapy. And again, the tissue and liquid biopsies, they are not always successful. And osimertinib, we know, is potent drug and is associated with significant survival benefit as first line therapy. And also we have uncontrollable controllable factors in sequencing, which is toxicity to the drug, occurrence of T790M mutation, sites of progression, concurrent morbidity, and patient's choice. So coming to the real world studies with first line osimertinib, so the data from the real world was collected and it was presented. So the flower, it was first line osimertinib in the real world view. So this data was collected from Italy. So in the real world, as the patients have adeno and squamous, both were there. Median age was 68 years. Patients who had PS more than 2 were also there in the study, and the patients who had brain mets at baseline, they were also there. So majority of patients, they had partial response or stable disease. So if we look at the time to treatment discontinuation, it was 25.3 months, which was comparable to that in the study arm, and PFS was 18.9 months. Again, the flower study, what it said, so will not go into the detail. The only thing was when the analysis was performed, there were resistance mechanism which was still druggable in few of the patients. So we have options beyond progression in few of these patients also. And again, talking about the common adverse events, diarrhea, skin rash, paronychia, they were there, but majority were grade 1 and 2. But this real world experience showed there was more incidence of venous thromboembolism, which we need to monitor. But they correlated that there was no difference in rates of venous thromboembolism according to the age, PS, comorbidity, and tumor load. So Flower confirmed that osimertinib's effectiveness in safety in the real world, but we need to worry about the thromboembolism events. Then OCFEC, this was a study data collected from Japan. Again, the patients with more than PS2 were there. So again, the patients with exon 19 and L858R mutations were there in the study. So same thing, the median observed, the PFS was 20.5 months and median time to treatment failure was 19.1 months, which was comparable to that of the clinical trial picture. So here in Japanese patient, the side effects which came out to the pneumonitis was much more higher as compared to the other studies, the other drugs which was there. So in Asian patient, probably it is a drug related, which we need to see and worry about, and we need to monitor. So Mykonos was the real world study, which was the global study. It was done in USA, Japan, Germany, and China. Again, if we look at the real world time to next treatment or death, the median follow-up time was 9.6 months, and the real world time to next treatment or death was 17.9 months. And real world time to treatment discontinuation was 17.2 months. So again, these results from the real world data, it support the effectiveness of osimertinib in the real world population. Longer term outcomes will be evaluated later when the final results come. So coming to the guidelines part, what the guidelines say. So NCCN osimertinib is the preferred category 1 recommendation. The other drugs are also recommended, but the preferred category is osimertinib in those patients who have EGFR exon 19 deletion or L858R mutations. And if we talk about the ASCO guidelines, so patient with squamous or non-squamous cells carcinoma, if they have sensitizing L858R or exon 19 del mutation, then the osimertinib is the first line therapy to go to, and it has strong data to back it up. And we have data to other therapies also, like Gefapixant with doublet chemotherapy and other monotherapies with other TKIs. But the best data is with the osimertinib in the first line. So summarizing, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in OS. The median OS benefit of greater than 3 years. It has set a new benchmark for osimertinib, and it provides a window of opportunity for the management of patients with stage 4 non-small cell lung cancer who have sensitizing mutation. So reaffirming its importance as a first-line therapy. So FLORA was the first study which has shown osimertinib, TKI, in which the benefit has translated from PFS into OS. And at 3 years also, about 30% of patients were still receiving osimertinib. And it is the drug which can be given in patients who have brain metastasis and T790M mutations at presentation. So it is the safest and least toxic drug among all the available options. And sequencing can't be considered the best strategy, as 70% of patients later may not be eligible to receive osimertinib in the second line. So these data, they confirm osimertinib as the first line standard of care in metastatic EGFR mutated non-small cell lung cancer. With this, I'll stop here.
Thank you, Dr. Sumit, for decoding the TKI role in EGFR mutation. And now we will have a discussion on a metastatic adenocarcinoma patients in clinical practice. And for that, I would like to call my all panelists, even Dr. Sumit Goel, Dr. Jyoti Gaja, and Dr. Bharat Dua, the speakers. But we have two eminent pathologists, those who are having a wide experience of this clinical practice. Dr. Jyoti Chakravarti, the head of the Department of Pathology at Venkateshwar. Dr. Shruti Dogra, the senior consultant of pathology at Venkateshwar Hospital. We have an interventional radiologist, Dr. Roshan. So this is basically, and we have our surgeon. The surgeon is very important once we are talking about lung cancer. Dr. Saurabh Gupta for the discussion.
Good evening.
Good evening, Saurabh. Means I don't know whether Tarun joins or not, but I'm just discussing the case. So 54-year-old male, former smoker, 20 packs per year. And there is a significant history of diabetes as a comorbid condition. PS. So comorbid condition, diabetes, PS is 0. But the important thing is that he had a history of pleuritic chest pain. And this is very important. And shortness of breath over the past 1 month duration. And Saurabh, Jassi and Dr. Roshan.
Good evening, sir.
Good evening. This is the CT scan of chest. And the tumor size is 4.2:3.7. Large left lobe pulmonary disease, a mass seen. And in abdomen CT, Dr. Saurabh and Roshan, right adrenal gland met seen. My question is very clear. Dr. Roshan, would you like to go for biopsy from both the sides? Or Dr. Saurabh, only one lung biopsy is sufficient for diagnosis? Dr. Roshan and then followed by Dr. Saurabh Gupta.
Sir, as I can see in the images, there is a speculated marginated mass in the left lung, along with a lesion in the adrenal. So my first suspicion will be it may be a case of CL lung with adrenal mets.
Okay.
So first of all, I'll go for a lung biopsy.
Okay.
And we'll wait for the histopath to come out.
CT guided or a bronchoscopy?
CT guided, sir. Actually, it should be done bronchoscopy guided. But if our respiratory team will advise, if they will go for bronchoscopy guided, it's fine. Otherwise, we can go for CT guided biopsy with the risk of some kind of hemorrhage in pneumothorax in this case.
Dr.
But
Saurabh.
ideally, it should be done bronchoscopy guided.
Okay.
Sir,
Dr. Saurabh.
I agree with him because the diagnosis or the tissue biopsy should be done from the primary lesion so that we can even do the molecular markers which are more reliable if it is done from the main tumor rather than from any metastatic site. So here it is an adrenal lesion, but even if there is a superficial, suppose left supraclavicular node, still I would prefer doing a biopsy from the main pulmonary lesion, even if there is a risk of pneumothorax, because the molecular studies are better done on the primary tumor tissue.
Means, Dr. Saurabh, any possibility of a cure in this case if there is a oligomats of adrenal only? If suppose there is a new targeted therapies, new immunotherapies and patient has a CR, do you feel that there is a chance of a surgery in such cases?
Sir, surgery, I'm not sure. Oligometastatic cases do not behave like metastatic, but still, I think immunotherapy and TKI will work better, and there would be a survival PFS of around 24-30 months, as we have already discussed. But surgery, I would be reluctant, sir.
Okay. Means just see, as Dr. Roshan mentioned and Dr. Saurabh Gupta clearly mentioned about that, the biopsy is suggestive of adenocarcinoma. My question to Dr. Jyoti Chakravarti is that, Madam, adenocarcinoma is a sufficient diagnosis in a present era where we discuss about the biomarkers role, we discuss about the targeted therapy. Would you like to add anything in the adenocarcinoma lung if there is a diagnosis? Madam, Dr. Jyoti Chakravarti.
Yeah, good evening, sir. Good evening, everyone.
Good evening, madam. There is a diagnosis of adenocarcinoma. As a pathologist, what is your recommendation in the present era once we are talking about biomarkers role, checkpoint inhibitors? This is sufficient for treatment adenocarcinoma, or would you like to go for some special test?
No, that is good enough. If we go for primary, say, tumor, then it is, we don't have to establish that it is from lung. Only one marker can help it. And later on, once the marker are put, we can always say whether it is adenocarcinoma or neuroendocrinal or squamous cell. That can be very well differentiated. And later on, the same paraffin block can be used for molecular studies also.
Okay. Molecular study. Means Dr. Shruti Dogra is here. Dr. Shruti Dogra.
Good evening, sir.
Good evening. My question is, 3 marker only or NGS?
Sir,
means 3 marker EGFR, ALK and PDL1 and otherwise NGS.
Yeah, 1 minute. Hello.
Yes.
Am I audible, sir?
Yes.
Sir, we started with, I've seen your images, and for diagnostic point of view, first I would like to say that before biopsy, even we can go for TBNA, cytology smears, and cell block too.
Okay.
So first point is that even if we are not able to get tissue material, we can go for TBNA, we can prepare a cell block, and if the yield of the cell block is good, we can go for IHC and molecular markers on the cell block. Because always tissue is an issue in lung biopsies always. So we have to be careful for that. And then now your next part is like adenocarcinoma lung. Once we have established via IHC that it is an adenocarcinoma, after that, testing for the biomarkers is the next step which we have to recommend. And for that, sir, whatever the driver mutations are there, that we will have to address. Like we have to, firstly, for adenocarcinoma, EGFR is there. After EGFR, we have to do for KRAS and BRAF mutations. And along with that, we have so many gene fusions which are there, like your ALK, ROS1, and your NTRK, and your RET proto-oncogenes. And for this, we have so many platforms these days. We have the NGS, then we have RTP, real-time PCR is there. And as screening, IHC is also good enough. IHC, which we do, though the as already highlighted by other speakers, that the sensitivity and specificity may not be that good, but as a screening modality, as a cheaper and a faster result it can give us. So for few things, we can use the IHC platform too, sir.
Okay. Dr. Jyoti Chakrabarti, my question is that suppose there is a diagnosis of adenocarcinoma, and Dr.
Yes.
Shruti mentioned about the NGS and the other biomarker, and routinely this will take a roughly 2 weeks time.
Yeah.
As a clinician, what I will do in between?
Just wait. Nothing else. What else can
Sometimes the patient say
we
that
can
doctor,
give you very fast TBNA cell block results can be given within 24 hours, and we
okay,
usually give it very fast. The
Mhm.
biopsy reports also will come very fast. But so far the molecular studies are concerned, sir, then we
Mhm.
will have to wait.
Means
Because
should
it
I
takes
start
time.
the chemotherapy and wait for the marker?
We can always tell you whether it is adeno or not, whether it is neuroendocrine or not. So that if that can help you to start the treatment, then
Mhm.
that is good enough. Otherwise, if you want targeted therapy, then definitely we'll have to wait, sir.
Okay, okay. So this patient is having a histopathology adenocarcinoma, and Dr. Shruti as well as Dr. Jyoti Chakrabarti clearly mentioned EGFR mutation positive, L858R positive. Then question is, Dr. Jyotika and Dr. Sumit Goel, Dr. Bharat, anybody, you can decode, Dr. Smith, very nicely. What would be your treatment of choice of this patient with EGFR mutation positive? First generation TKI, second generation TKI, third generation TKI, or a combination of the immunotherapy plus chemotherapy or chemotherapy? Anybody can take. Dr. Sumit Goel. Dr. Sumit. Dr. Jyotika Jain.
Sir, good evening, sir. Yes, sir. Sir, sorry, I missed the first part, sir.
Means I'm simply saying you decode the things very
Yes, sir.
clearly. So patient is having a stage 4 non-small cell lung cancer, EGFR mutation positive, and as per your decoding, what is your choice?
So
The first
obviously,
generation,
number 3, osimertinib, sir. There is no doubt about it.
osimertinib. So
Yes, sir.
Sumit is absolutely right because he decoded the things, and I will like to show the guidelines, the preferred one. As Sumit mentioned, I am showing all these Sumit slides only as evidence. Osimertinib has been given a preferred recommended first line treatment. So my question is, efficacy, safety, quality of life, overall survival, Dr. Sumit, would you like to see as a first line treatment or some other factor like cost or the first generation TKI?
Sir, there are two things. One is the cost, other is the science. If you look at the
Yes,
science, sir, clearly the efficacy wise, safety wise, quality of life wise, and the OS and PFS.
yes,
The osimertinib is the first line recommendation, sir, and in clinical practice also, uh, we have seen the tolerability is much better. And
mm-hmm.
once the patient start osimertinib, the benefit comes very rapidly, and the
Mm-hmm.
patient is happy because the side effects are very less. So
Yes,
initial few months, patient is about like he's worried, then they even forget that they are suffering from the disease. So
okay.
looking at all the factors together, yes, osimertinib, I will always prefer in the first line, sir.
Means I totally agree with you because you decode and the treatment options. As you mentioned, I'm showing your slides only, Sumit, nothing more than that. 18.9 months versus 10.2. And as a third generation TKI, if you compare with the first generation, second generation, osimertinib has shown a best response rate and overall survival. Will type of mutation change your choice of treatment? This question is for Dr. Jyoti Chakrabarti and Dr. Shruti. Anybody can. Means Dr. Jyoti and Dr. Shruti, EGFR, we are talking about deletion 19, 21, 20. Can you elaborate?
So, like if we are talking about the EGFR mutations, so now mutations have to be specified and identified, whether
Yes,
it is exon 19, whether it is
yes,
exon 20, or whether
yes,
it is T790. And
yes,
so there are 6 to 8 specific mutations which have been studied and which have been related to the therapy response or resistance.
yes.
So we have to specify in our EGFR mutational study that as to which of the exon 19 or whatever is being highlighted, because then precision therapy will be according to that only.
Yes.
And
yes.
I want to highlight that 90% of the adenocarcinomas with EGFR are on exon 19 and
Okay.
around 40% on exon 21.
Okay. Yes. Yes.
And
Dr.
sir,
yes, 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 Shruti, yes,
sir,
yes.
and one more point, and whenever we have with T790 EGFR, then it is related with resistance and relapse. So that is very important for everyone in this platform. That EGFR, I mean, just to say that it is EGFR positive, we have to go further deeply into it as to which of the mutation is getting highlighted, because it will be have direct it is associated with the response and resistance both.
I totally agree with you, Dr. Shruti. As a pathologist, you are given such an insight that this is very important. Dr. Jyoti Chakrabarti, how many cases you can see this is a rare one that EGFR mutation 20 sometime positive.
Yeah, EGFR is very commonly seen, sir. So
Yes.
in Asian population, it is almost 40% we find in adenocarcinoma.
Yes.
And nowadays, even squamous cells is showing at least 4% with EGFR mutation. So this is a newly, it's a newly found thing that for STC also nowadays EGFR should be done.
Sumit, any treatment option will change?
So
if
definitely
19
yes,
and
sir.
21 is there, and if
Definitely,
20
sir.
is there.
The guidelines clearly say sensitizing EGFR mutations for TKIs.
Yes.
So again, the type of mutation will give us insight whether to treat it with TKI or not. Suppose that insertion 20 mutation, they may not be sensitive to EGFR TKIs.
Yes.
Again, then if it is like there is a T790M mutation in the EGFR pathways, that is again, it is a resistance pathway where osimertinib may still work, but other TKIs may not work. Then the relative efficacy compared to afatinib versus osimertinib in L858R versus deletion 19, that is matter of debate, sir. But yes, we need to know the type of mutation, which is important, as Dr. Shruti highlighted. It is very important, sir.
Okay. Just see, this is again a slide of Dr. Sumit only, that progression-free survival was primarily the endpoint in this FLORA trial, and shows a better result with the deletion 19 and L858R mutation with osimertinib 21.4 months versus 14.1, and osimertinib has shown highest overall response rate and median overall disease control rate response. Dr. Sumit, how important is overall survival for picking the EGFR? Means, as you mentioned that only 3 patients, you have shown your case that out of 10, only 3 patients are available for second line treatment if you are not switch on the osimertinib. Can you highlight this?
So overall survival is the only point which I will go for. If so, the number one point for me to choose any treatment is the advantage in terms of overall survival. So definitely it will be the number one factor on the list in choosing a treatment option, sir.
Okay. Dr. Jyoti Chakrabarti, means are you doing a T79 mutation in the beginning, or you are waiting?
We are outsourcing. Actually, we are not doing in this lab.
Okay.
We are getting it done from outside.
So how we are doing this, on a paraffin block or?
Paraffin block, yeah. Formalin fixed, paraffin block.
Okay. How much time we will take for this?
Usually 12 days, they say, sir. 10 to 12 days.
12 days.
Yeah.
Dr. Shruti, any comment on T790 mutation in adenocarcinoma patients?
So, right,
your
sir.
expert opinion on T790 mutation?
So, to remember all the mutations is very difficult, but EGFR is a very common one. So I will highlight again and again that commonest is exon 19, which is 90%. Then we have exon 21 mutations, which are commonest. And also, if histopathology, histomorphology is of lipidic features in adenocarcinoma is it goes in favor of exon 19 and 21, which is commonest, and more so in females and non-smokers. And on the contrary, the one which you are asking me is T790 is on exon 20, which is associated with resistance and relapse and poor prognosis for the patient. So for EGFR, these are the three mutations which we can all remember broadly, sir.
Okay. Okay, Dr. Jyoti Chakrabarti, my question is any difference in the biopsy of the primary versus the metastatic disease for TKI?
Sir,
EGFR
so far,
mutations?
no, I don't think so.
I don't think. That means
Yeah,
there is a
It's the
discordance.
same, similar kind of genetic mutation is seen.
So just see the FLORA trial, median overall survival more than 3 years. I'm not going in detail of this because Dr. Sumit already spoken about this regarding the Lux 7 and ARCA trials and Canadians biopsy. The question is, considering that in EGFR positive non-small cell lung cancer, 25% patient presented with brain mets at the baseline and 50% as a lifetime. Dr. Jyotika, would you like to go for a MRI or Dr. Saurabh? Once you are investigating such patient, MRI for brain?
Yes, sir. MRI should be done if either an N2 disease or a tumor more than 3 or 4 centimeter in the lung.
Okay.
Not for stage 1A, but yes, more than that.
Sir, I will also agree with Dr. Saurabh. So definitely, in these cases, we would like to have MRI.
Okay, my question is, Saurabh, this patient presented with stage 4. In the beginning, would you like to go for MRI?
Yes, sir. Because yes, because at the time of presentation, sir, I may be vaguely correct, but 23 to 27% of the patients, they have brain mets at the time of presentation. So
Even
MRI,
even asymptomatic.
asymptomatic. Yes, sir. Yes, sir.
Jyotika,
Yes, sir. This patient definitely will go ahead with that. Patient is already metastatic M1 disease.
Okay. Dr. Roshan. Hello, Dr. Roshan.
Sir.
Means patient is asymptomatic and I have presented that lung and adrenal mets only, oligomets.
Sir.
What is your opinion as a radiologist? The MRI of brain in such patient?
Sir, I agree with Jyotika ma'am, Dr. Saurabh. MRI brain contrast must be done in this case.
Okay.
As it's a case of metastatic, already known metastatic disease.
Whether asymptomatic or symptomatic stage 4, the guidelines clearly say that MRI should be done according to the NCCN guidelines. Dr. Sumit, any comment?
Definitely, sir. Definitely, sir. I would like to go for the workup from brain mets. It is important, one, to know whether they are present upfront or not, or they have, like the disease has progressed, they have come later.
Okay. Okay. Dr. Bharat Dua? Dr. Bharat Dua, any comment? So this is the study which clearly showed that brain mets basically. So Dr. Sumit, hypothetical scenario. As the biomarker explained by Dr. Bharat Dua that PDL1 positive and EGFR mutation positive. What is your choice of treatment in such cases?
So when the sensitizing driver mutation is there, irrespective of the PDL1 positivity, the treatment remains TKI.
TKI.
Yes.
Means whenever there is a driver mutation seen, TKI. And this is proved by the evidence that there is no role of immune checkpoint inhibitors. If the EGFR mutation is positive, the response rate is much less and not advisable. So, Dr. Sumit, safety you mentioned about that.
Yes, sir.
You mentioned about the DVT and non-infectious pneumonitis. How many cases you feel that seen by this TKI or with the immune checkpoint inhibitors?
Sir, with TKIs, so far, not seen any, sir. So initial days, we were worried about two factors. One was the liver function test, other was the cytopenias, and the third one was the QTC on the ECGs.
Yes, QTC.
But QTC definitely we need to monitor when the patient is in osimertinib. And though the data has said there is higher chances of venous thromboembolism, so which we need to be careful about. And pneumonitis, yes. But if we talk about immunotherapy, checkpoint inhibitors, they are totally unpredictable. So we need to be very much careful about the pneumonitis, colitis, hepatitis, and there are so many other confounding factors also.
Endocrine factors.
Endocrinopathies, yes, definitely, sir.
Yes.
And TKIs, I feel overall the safety profile is better as compared to the checkpoint inhibitors.
Dr. Roshan, my question is, suppose there is a mass in the lung and the patient is on TKI versus immunotherapy and develop the non-infectious pneumonitis, how you can differentiate disease versus the effect of the immune checkpoint inhibitor or TKI as a non-infectious pneumonitis? Any radiological parameter where you can say that this is a non-infectious pneumonitis versus the
First
tumor?
of all, we'll compare the present study with the previous scans.
Okay.
And we'll go for the symptoms the patient is presenting.
Okay.
And along with the other parameters, blood parameters, we'll end up in a decision whether it's metastatic disease or some infectious disease. And I will follow the patient for successive scan before deciding that it's a metastatic way. Because as we have discussed in the earlier session, immunotherapy drug regimen, it many times falsely present as advancement of the disease. As
Yes,
you mentioned earlier.
pseudo-progression of the disease, pseudo-progression of the tumor.
Pseudo-progression of the disease, sir. Right.
Yes.
So we can follow the patients for 4 weeks. After 4 weeks follow-up, we can go ahead with another HRCT test to look further it was a pseudo-progression or actually it's a disease advancement.
Okay. So, Sumit, if you see the summary, they clearly mention about that the toxicity is much less with the third generation TKI. You have already shown that Lux 52%, 66% with the second generation TKI, and only 4% with the third generation TKI. Means, Dr. Sumit, how much you are giving a importance of quality of life in such patients?
Definitely, sir. The quality of life is matters. So suppose there is a medicine which is likely to improve the survival, but the patient is likely to stay more in the hospital. So obviously, I will prefer a treatment where the things are balanced. Probably the patient where the quality of life is better will be preferred over one with less over those with more side effects. Yes, quality of life definitely matters, sir.
Okay. Dr. Jyotika Jain, number of times we are giving a chemoradiotherapy to the patient in lung cancer in stage 3B. How do you put quality of life is in lung cancer patients?
So nowadays we are having good modalities like we are having 4D CT planning, gating, respiratory, and along with that IMRT, IGRT techniques. So you can just minimize the volume receiving the dose. OARs can be controlled very well nowadays. So all those side effects you still see at the during end of the treatment, like esophagitis and some of the features, they do come, but you can minimize them with the newer techniques nowadays.
Okay. Dr. Saurabh Gupta, as a surgeon, suppose patient is having an early stage lung cancer and you did a lobectomy.
Yeah.
So quality of life, how much matter as a surgical part also in early stage lung cancer?
So lobectomy is not a morbid procedure if the preoperative pulmonary function test is encouraging.
Yes.
Because there's only chances of pneumothorax or bleeding. So if we can tie the vessels properly, a lobectomy is a very safe surgery. And it is even nowadays we are doing this by VATS or robotic approach. So the pain associated with this is also very less. So pneumonectomies are very safe and rewarding surgeries, sir, if patients are properly chosen.
What is your opinion regarding the robotic surgery?
Yes, robotic surgery, definitely it is a very great tool in such
you have
surgeries.
facilities at your center.
Yes, so we have the facility and we can do this surgery very efficiently with robot because the degrees of movements are great and the visualization magnification is much better, so we can easily ligate and the cautery is good. So yes, this surgery can be very easily and efficiently done with minimal access approach also.
Okay, okay. Dr. Jyoti Chakrabarti and Dr. Shruti, as Dr. Roshan mentioned about sometime there is a pseudo progression of a tumor and a clinician feel could be a disease and he took a biopsy again by bronchoscopy or CT guided. Any difference in pseudo progression versus the tumor?
Sir, we have to find the neoplastic cells, that's all.
Okay.
So
Suppose there is no neoplastic cell, then it's a pseudo progression?
then we will just call it there is fibrosis or whatever necrotic material is there. So we only look for neoplastic cells, sir.
Okay.
Viable cell, viable. That's all.
Means, as a pathologist, Dr. Shruti, what is basically it means you feel that pseudo progression tumor has? As a pathologist?
So pseudo progression, if in radiology, we feel that there is a pseudo progression and there is an increase in size of the tumor and it looks like a tumor. But that can have many causes. Like if it is a pseudo progression, we have to rule out granulomatous diseases, which are very common in oncology patients. We have to, and for granulomas, we have to granulomatous. Fungal etiology is also very common, as well as tuberculosis. We have to rule that out. And as Dr. Jyoti Chakravarti ma'am is highlighting, that once we get a biopsy, we have to really see whether it is just a pseudo the tumor kind of an inflammatory thing, or it is actually a neoplastic thing. And many a times there may be confusion as to reactive mesothelial cells, or sometimes the inflammation is so much that we cannot rule out that it is a neoplastic, and those are the times that we take help of IHC then, sir. We put immune.
So
right, sir.
Clearly explain the things. So considering sequencing, I would like to say ositinib is a treatment of choice, and I would like to say Dr. Sumit has shown already that 3 patients only go for a second line treatment. So I can conclude of the scientific program of panel discussion that the final overall survival analysis of FLORA trial in favor of ositinib as a standard of care and decoding methods and standard of care in a present era. Thank you very much for your kind attention and for a lovely discussion in this panel discussion. I thanks all the eminent speaker, the panelists, those who participated in this long conclave, and I hand over the mic to the organizer for vote of thanks. From my side, good night to all of you.
Good night.
Okay. Good night, sir. Thank you, sir.
Very much, sir. It was really wonderful
Thank you, sir.
discussion.
Okay.